So, welcome to college, right? So this is not a fly-by-night massage school, and we don't just kind of, let you name a couple muscles and graduate and stuff like that. Yesterday was college level anatomy starting to come at you, and it will be something you can manage. Again, we have a 95% graduation rate because we have a plan. I have a plan. But what we were doing yesterday that I'm actually very proud of that we do here that I feel like other schools don't do is we're starting to teach you anatomy in terms of kinesiology. Remember, people get degrees in kinesiology. They get a kinesiology degree. So just to learn about how this stuff moves. So it is tricky. And so what I wanted to do was I put tape all over the skeleton to try to show you guys some of the trickier stuff that's going on, because some of the feedback I got was, hey, it's hard to visualize this stuff. It's really hard to visualize this stuff, and that makes perfect sense to me, right? And so unfortunately, if you're not a visual learner, you need to be a little bit of one now, because you do need to visualize some of this stuff, but I'm going to tape it off here. You might want to pin me to your screen and make me as big as possible, so at least make the skeleton as big as possible, so that we can look at some of this stuff. Yeah? By the way, I'm available to go over your tests with you. I had somebody yesterday who I thought was being very smart, actually, who had me just go through their entire test with them. And we talked about stuff that they got right and wrong, and why it's right and why it's wrong, and all that kind of stuff. So if you're ever feeling like, even if I got through that, I want extra help, we can do a one-on-one session where we go over it. Like, why is it this way? And sometimes that's very helpful, right? So I just want you to know I'm available. Yeah. Cool. Okay. So let's talk about this. Do you have any questions, by the way, before I get started? Just questions where you're like, this is burning in my brain. Please answer this for me. I still remember it. It's driving me crazy. Anything.
I do.
Yes,
So,
Ms. Torres.
Okay, so one of them was about the Teres Major, what shortens it, and I have really hard time understanding that.
It is.
There was two answers that could be the right answer, which one of them was the adduction, and then the other one was the lateral, I think it was the lateral rotation.
Yeah. Hold on, I'm setting up a model here for you to kind of help with this. Okay. This is about the Teres Major, right? Okay.
Yes.
So believe it or not, this is kind of a model. Let's see if I can do a little bit better. There we go. This is you looking at somebody from the back.
Okay.
Back here. This is their armpit. This is their Teres Major coming off the side of their scapula. It actually wraps around in front here. By the way, that's why you can do a medial rotation with your Teres Major, because when this pulls, it's grabbing in front, and it actually rolls the shoulder in a medial rotation. Anyway, is abducting it going to make it longer or shorter? It's actually going to make it longer. It's going to pop right off here, right? It's going to make it longer. Adducting it will get shorter because it has to contract to adduct. I don't know what the answers on the test were, but that might help you think about it a little bit.
Yeah, so that was one, but what about if you do the lateral rotation? That one shortened it too, right?
No. So lateral rotation, here, you couldn't do this with your shoulder, but I'm going to do a ridiculous lateral rotation with this, okay? So when it contracts, it actually does, hold on, let me get this. I'm trying to look in reverse here. When this thing contracts, because it grabs the front here, it actually does a medial rotation. But let's see, if I did a lateral rotation, this thing would stretch so much that eventually I'd pull it off. It's actually getting longer on a lateral rotation. longer.
Oh.
Because it's winding it away. It's winding it away.
It's because, yeah, now I understand. It's because it attaches to the front of the greater humerus, not to the back. Okay, I get you.
Yes, and by the way, I tried to show you guys, maybe I'm being offensive here. I tried to show you guys that, but it's so hard to see. You're absolutely right. And what Miss Torres said is actually brilliant. This is true of the lats and the Teres Major. The lats, can you see our skeleton here? I've got the lats in yellow here. They're going underneath the arm, and attaching in front. So when they pull, they actually medially rotate the arm. When they pull, they actually medially rotate the arm. It's one of the things they do because they reach up from underneath. Does that kind of make sense? I hope. Yeah, maybe. Cool. Any other questions before I kind of review everything too? I'm not going to review the whole test, but I'm going to kind of review the concepts.
I have a question.
Yes, ma'am. Please, Miss Monreal.
Okay, it was question 22. Bilateral contraction of the upper fibers of the trapezius will create what movement of the head and neck?
And the answer is extension.
I put... Oh no, I'm reading you the wrong one. But still, so let's go over that one because I got it wrong too.
By the way, you and about half the class. So let's talk about this because the stuff that messed people up the most was unilateral and bilateral movement of the traps and what it does to the head and what it does to the shoulders because it's super confusing.
That was the one.
All right.
Yeah.
So let's talk. I hope you guys can see this. I have made the traps on the skeleton here. I made them in two different colors so we could talk about different sides. There's a pink side to this trapezius, and there's a yellow side to this trapezius. And by the way, I mean, if there's a real trapezius, it'd all be filled in here too. But I just didn't have that much tape. Okay? So, and this black around here is just to hold these on the head. It has nothing to do with anything. But this is kind of the superior nuchal line. This is about where the superior nuchal line is a little lower, but this is about where it is. It works for our purposes. Okay? Now, first, what does bi mean? Two. And what does bilateral mean?
Out further?
Bilateral means both sides. So that's lateral and that's lateral. They're saying both sides. And so that might have been the first confusing part for people, right? Is when they say bilateral, they mean are both sides of this muscle working at the same time? Because your trap can just have one side working. Anybody know what it's called when one side's working only?
Unilateral.
Unilateral, exactly. So unilateral would be as if this little pink side's pulling. Bilateral would be both pink and yellow. So two different things can happen when it's bilateral, and two different things can happen when it's unilateral with the shoulders. So let's talk about some of the simple stuff first. If the shoulders, if the upper trapezius bilaterally contracts, it elevates the shoulders. Can we all see that? If you can, it's okay. It's totally okay. But I need like a nod if you can. If both sides here contract, can we see that my shoulders, that's one of the things that could happen. One of the things that could happen. Right? In fact, do this with your shoulders and feel that muscle back there. In back, that's your traps. Are you with me, Mr. Kandars? Good. Just want to make sure you can see me.
Yeah, I saw my phone point up.
Cool. As long as you can see me. So that is one of the things, because this shortens, right? It shortens and it lifts my shoulders up. That's what it does, right? but we have muscles that will hold our shoulders down. And if I was like, let's say, it would actually be a muscle, but let's say that that somebody wanted to do a trick on me, so they sewed my shirt down here and I can't lift my shoulders up anymore. Now what happens if I bilaterally, both sides of my traps pull? My shoulders can't come up, so what they're connected to has to do something. And if I pull both sides of this, if you had two ponytails behind your head and I pulled both of them, thank you, Miss Petrie, you would do this. I just pulled on the back of your hair. It's the same thing. I would show you the skeleton, but the skeleton's head doesn't go back. But I'm just pulling two ropes, and if the shoulders don't come up, then the neck has to come back. Because they shorten, and so something has to get closer to something else when things shorten. This finger has to get over here, or this finger has to get over here. My shoulders have to get up here, or my neck has to come back to meet them. Do this with your neck. Feel in your traps, you'll feel that they're tight too. Right? You have shortened the back of your neck and you've lengthened the front. So those are the two bilateral things. Yes, go ahead.
So that's, okay, so if you're putting your head back, is that flexion of the trapezius, or?
It's, well, don't think about the muscle. So how do I explain this?
Okay.
So, I mean, do think about the muscle, but when we talk about flexion or extension or whatever, we're talking about just what bones and joints are moving. This is extension of my neck. There's lots of things that can cause extension of my neck. In this case, the trapezius, both working bilaterally, causes extension of my neck.
Okay.
Because extensions usually happen behind you.
Okay.
An extension of the neck is the answer.
So I got confused because I'm thinking of a muscle contracting, so I'm thinking, that's why I thought lateral flexion, because I was like, okay, well, it's flexing. I don't know.
Yeah.
Never mind, but you explained it.
No. Good thinking, Miss Hunter. No, several people have mentioned the problem that you're having. Just the word flexion alone kind of throws us off. You guys think flexion means contraction. So you're like, well, that muscle's contracting,
Yeah.
It must be flexing. Flexing and flexion are two just different things. I'm sorry they sound alike, but they're just two different things. I have to flex a muscle to do a flexion, to do an extension, to do an abduction, to do an adduction. All those require me flexing a muscle, but that's not flexion.
Okay. So when we say like, even with the arm, to flex it is to bring it up, to extend it is to take it down.
Or, yeah.
Right?
Yes.
Okay, but are we talking about muscles, or again, how you referenced, is it the bone? What are we talking about? I'm just trying to comprehend my thought process.
Sure. Let me think here. I'll do it with this little guy here first, because I got other stuff to show you. We're still on the trapezius, everybody. But I right now am flexing, creating a flexion of this doll. It doesn't require any muscle for the doll. This is just, consider a flexion if it goes this way. I can make you do a flexion, you can make you do a flexion. Right? I can make you do an extension, you can make you do an extension. So, flexion, extension, abduction, adduction, pronation, supination, elevation, depression, protraction, retraction are describing movements. I could get in a car accident, and the accident could cause me to do a flexion of my head. It doesn't have to be a muscle. But if I'm doing it under my own power, then we study what muscles would have pulled and done that.
Okay, so just to go back to the question, bilateral contraction of the upper fibers, so the pink and the yellow are getting shorter,
Yes.
correct?
Yes.
Okay, so that's going to make the head go back.
Because they're tied to the back of your head, right?
Correct.
And so I pulled these two ponytails.
So
Yep.
it's just the terminology I got wrong, which would have been extension instead of flexion.
Yes.
Correct?
Yes.
Okay.
The
All
muscle
right, I'm good.
the muscle contracts, The trapezius contracts and it creates an extension of the head for bilateral.
Okay.
What you just described there was a question that a lot of people had trouble with, but there's another one that even more people had trouble with because it's even more confusing. And that's
I have problems with that one too.
probably 24. That's when the muscle works unilaterally. So, this one is really hard to visualize. So, unilaterally means just one side of this muscle is working, right? And we're talking about the upper trapezius right now. So, one of the things that can happen if this muscle works unilaterally is that I can raise one shoulder. In fact, you'll have clients come into you like this, and you're like, wow, something's not right. It won't usually be this exaggerated, but you'll see kind of this kind of thing. And they don't know it. And they're like, I don't know, I've got a little problem here. And you're like, yeah, you do. Anyway, that's unilateral elevation, right? That's my trapezius working on just one side or the other. Again, though, what happens if I hold down my shoulder and this shortens on one side? A couple things happen. You could argue that a little bit of what they call lateral flexion occurs because it kind of pulls my head over there. But here's the other thing. Because this thing goes diagonal, pay attention to this part because it's really confusing the way they say it, but it's not a confusing concept. If I pull this ponytail on this side, the head actually wants to go the opposite way. And think about it. If I had somebody with a ponytail here and I pull this side, their head actually wants to rotate. So yes, it can pull their head over to that side, but it can also help their head rotate. And your book says it helps the head rotate to the opposite side. And they mean it helps the head rotate to the opposite side of the muscle being pulled. And actually watch, the other muscle tightens here. It actually gets stretched. This is me unilaterally flexing the pink side here. Then if I unilaterally flex this side, look, the head actually moved. I'm actually able to move the head back and forth here. No, you're not. Yes, I am. Yeah. That's in part, by the way, you have other muscles helping this happen. But that is one of the things the traps can do. So I pull both, and I'm sorry to keep using ponytails, but just like visually in my head makes sense. Like from when I was in 5 years old in kindergarten, right? And if there's braids there in front of you, and you're being a bad kid and you pull both of them, your poor person sitting in the seat in front of you is going to do an extension. If I pull one, it's going to tend to turn their head because you're pulling from the back. And that's exactly what's happening here. Can you guys see that?
So
That example is actually really cool, so thank you.
You're welcome.
when you take your head like to the right, it shortens the muscles on the left. Is that what it was?
Yes.
Okay, 'cause that's what I got wrong.
Yes. Yes. It's a very confusing way to talk about it, but I think once you see it, all of a sudden you're like, oh, okay. And by the way, once again, I know I'm a broken record here, but sorry, 1 second, Miss Hunter. Once again, we're learning a new language, right? We're trying to talk about very complex things that your body does, and how do we talk about that? But Miss Jana has put it in nice, simple terms for us. You know, when you turn to the right, it's the left side contracting. With this muscle, by the way, other muscles might attach to other places and do other things. I hate to tell you, we've got lots to learn about, but with this muscle, because it's attached to the back of your head, look, I'm pulling it, and this head's looking to the right. Boom. Pull this side, it goes the other way. So yes, and Miss Hunter, you had a question, I believe?
No, I was just moving my hand.
Oh, I thought you were like kind of raising it, and then you're like, no, I'll wait. Okay, cool. So does that help a little bit? Just kind of put it in your head. Okay. So since we're on a roll, they're a little harder to see because the lats on this side is over it, but this is the lower part of the traps, right? Do we see how if I pull down on those because they're attached to the scapula, they'll depress my scapula, right? These are the lower fibers. You've also, don't forget, you've also got fibers on the trapezius running across. And these are the ones that if you pull, your scapulas come together and you do a retraction because your scapula is coming together. That's the middle fibers. Yes. And then, thanks to Ms. Torres' question, we actually already kind of covered some of the Latissimus dorsi and Teres Major stuff, which the really important part is that it reaches up underneath the arm. Underneath the arm. So it's actually coming up like this, underneath here. So, which is why if it grabs, because it can actually cause a medial rotation, right? And when my arms are way up high, is my lat stretched? Yes, it's stretched out. It's long here. And when it shortens, it pulls my arm back to my body. You can do it like this, which is an adduction. Oh, what?
What number 20, is this, I don't know, 23 or 24, I don't know which one is it. It says question 23, I'm assuming that's.
What's the
It says, which of the following movements occurs when the upper fibers of the trapezius is unilaterally contracted, which that's what we just did, but I don't understand the answer.
Okay.
How are they, the head and the neck, to the opposite side?
Okay. So, Ms. Torres, can you see your screen? Me?
Yes.
Okay. So, if I pull this, can you see this pink thing here? Pink trapezius muscle?
Yes.
Okay.
Yeah, I can see everything.
So if I pull this, do you see what the head's doing? All they're describing is this.
Yes.
If I pull this, the head goes to the opposite side. That's all they mean. They're just trying to describe that I pull on the left side, but I look right. Or I pull on the right side and I look left.
Okay.
So that's what they mean by it goes to the opposite side. It goes to the opposite side of the one working. This guy over here is working, and the head goes that way. It goes to the opposite side. It turns to the opposite side. Now this side's working, the head goes to this side. They're just trying to describe a movement. It's very confusing, but they're saying that when this muscle works, it actually turns my head to the opposite side. So when as Ms. Jaundice said, actually, when the right muscle contracts, the head turns to the left. When the left side contracts, the head turns to the right.
Okay, so I was thinking that it was the head and the neck to get. No, never mind, I got confused. But yeah, I understood what you just said.
Yeah. And by the way, it is the neck a little bit. Like a lot of twisting that happens right at C1 and C2. We'll get into that later, but some of it is your neck twisting a little bit. But it doesn't matter. The head turns to the right and left. Yeah. By the way, I too think this stuff is confusing. So I'm glad you're clarifying. I'm glad you're trying to process. Yeah? And by the way, I put a deltoid on here too because I thought it really visually kind of would help us. Do you see this is the blue is the, what fibers, Miss Hansen, are the blue here of the deltoid?
Are you looking for the anterior?
Anterior, the front fibers, yeah. And Miss Jaundice, what fibers are the green here?
The middle fibers.
Yep. Yep. And Miss Monreal, what fibers are the red fibers?
Posterior.
Posterior, yes. And they're all the deltoid. And by the way, if this was a real deltoid, there'd be a lot of red here and a lot of green, a lot of blue. But watch what happens to this arm when I pull the posterior fibers. The arm starts to do an extension. It actually starts to come back. I can't pull too hard because I'll rip the tape, but it's doing an extension. What happens to the fibers if this thing starts to flex? Does a flexion. The rear fibers start to lengthen.
And lengthen.
Yep, this is a stretch. But when they contract, you get an extension. Let's look at what happens when you pull the middle fibers. The arm starts to do what?
An elevation.
That's a scapula elevates. This arm is coming away from the body.
AB duct?
AD duct.
AB duct. Very good. Yeah. And let's look at the ones in front, because this really helps a lot. The ones in front kind of go diagonal here, just kind of like the ones in back, right? Kind of diagonal across here. So one of the things they do when they pull is you get this, right? What's this called? Anybody?
Flexion.
Thank you very much, flexion. But because they go diagonal, you also can get a little pull that pulls to the inside. It rotates to the inside. What do we call that when you rotate to the inside?
Medial rotation?
Medial rotation. And because this thing is in front, if you put your arm out here and the front contracts, you get a horizontal
Adduction.
adduction.
Adduction?
Adduction. Adduction. Cool?
So if somebody's trapezius were very tight and restricted, it would restrict the movement of the deltoid then, right?
Not
necessarily.
no, not
I
necessarily.
mean, like I was looking at where it crossed in the back. So if we're going like a triangle, or not like a diamond, and that was all tight, is it gonna restrict the posterior deltoid?
Not necessarily. The posterior deltoid, no, not necessarily.
No?
Yeah,
Okay.
they meet each other, but one doesn't grab the other. But
Okay.
but your thinking is on the right track, and let me give you guys a little teaser of why you're learning this stuff that'll make you such a better massage therapist. So honestly, 90% of the therapists, when you go to them with a tight shoulder, like tight trapezius up here, they rub your shoulders. And it feels good. And your shoulders loosen up a little bit. And you leave and they get tight again on you. And they get tight again on you because they don't fully understand kinesiology and they didn't catch all the tight muscles. And let me give you an example. You really need to think about this because it's actually the core of a lot of massage. Have you ever felt somebody with tight shoulders? Maybe your own. All right. They're tight because they're contracted, right? Just like when you flex a muscle, my biceps all soft now, and now it's hard. It's contracted. Your shoulders are tight because they're contracted, okay? Right? Does that make sense? Okay. So why aren't they up like this? Because sometimes my shoulders are really tight, but they're not up like this. And my head's not back like this, and yet they're tight.
Is another muscle pulling them down?
Yes! 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 It's that big a deal. My body wants to maintain homeostasis. It goes, this idiot's been working at the computer for 12 hours today, and he's been doing it for the last 40 years, and so he's like this, but I don't want him walking around like this because your body is so much smarter than you are. So another muscle pulls it down. What other muscle could depress my shoulders? My scapula.
Look at this dorsi.
Kind of, but what
Is
pulls,
it the
what pulls down
Oh,
my scapula? What depresses my scapula?
I thought it
does,
I
right?
thought it was the lateral with the.
I think you just said it, Ms. Torres. Maybe somebody else said it too.
Lower trapezius?
Yes! So wait a second.
The lower trapezius?
Are you telling me the trapezius can actually fight with itself? So, now Miss Monreal knows this. So now when I go to get a massage from her and I got tight shoulders, she rubs up here, but she also rubs down here and loosens up my lower traps. Why is this important? Because my body's trying to I'm tense, and my lower traps are trying to lower my shoulders, and my upper traps are fighting that, and my lower traps are doing that, right? And they're fighting each other. Have you ever gotten in an argument with somebody, and maybe you get over it, but they don't, and they keep messing with you, and then you get mad again? If you don't end both sides of the tug-of-war, for those of you that love tug-of-war, if you don't end both sides of the tug-of-war, you still have a muscle pulling. So the therapist that went to some other school rubs the shoulders, but their lower traps are still tight. And what happens when the body feels those still pulling is now the upper trap's trying to pull back again because you haven't solved the problem. You've only fixed half the problem. And so their relief lasts a couple of hours, but then it's back. But they go to Miss Monreal, and she fixes both spots. And they go, you know, I don't know what it is about you, but when I see other therapists, they do a pretty good job. My shoulders feel better, but they only feel better for about a day. But when I go to you, I feel better for a week. I can't figure out why. And Miss Monreal giggles to herself because she knows it's her advanced understanding of kinesiology. And she knows that trapezius can actually fight with itself. And so she makes sure to unwind the top muscles, unwind, so to speak, loosen the top muscles, and loosen up the lower traps because she knows the traps can actually elevate and depress the shoulders depending on which fibers you're talking about. That's why we're studying this. That kind of stuff. That's what's exciting. That's what will make you a better massage therapist. And that's just a taste of that. But that's the concept. It is neato. Thank you very much. It's super neato cool, right? And I don't even consider myself much of a geek. It's not even that I'm geeking out on this. You know what it is? I like clients to walk out of my room and say, you're better than any therapist I've ever had. It feels good. I like to win, right? I want them to walk out and be like, how did you know? I was complaining about this up there. How did you know I hurt down here? I didn't know, but I had a pretty good idea because I know how bodies work. And then what they do, they give you a hug. Sometimes they cry because they've gotten so much relief, and they slide cash in your hand. That's a pretty good day to me. All right? Love and money. Oh, both are wonderful. Yeah. Money, money, money. Cool. All right. So that's why we're going over this stuff. That's why we're hurting your brains. It's going to get better. But I'm seeing people really grasp this concept already, and we're just getting started. So this is good. Cool? Cool. All right. Let's really quickly review movements. Okay? And by movements, I mean flexion, extension, abduction, adduction, elevation, depression, medial rotation, lateral rotation, retraction or adduction of the scapula, protraction or abduction of the scapula. Because that's the other thing that's throwing you off right now is that you're like, I got to think about the movement and then the muscle and it's flexion and extension. It's a lot, right? Cool. Okay. All right. Miss Nguyen, what am I doing right now? Elevation, yes. And am I elevating my scapula? Just say yes. Yes. I'm elevating my scapula. My arm might be coming along for a ride, right? But it's the scapula that's elevating. Right. Scapula that's elevating. All right. Very cool. Thank you, ma'am. Miss Bilateral. What am I doing here? It's the same question. Elevation of the scapula. Which muscle is responsible for that movement of the four you just learned?
The trapezius, the upper.
Yeah. Did you just memorize that? Or did you kind of know it because you now know there's a thing up there and it's going to pull up my arm?
We also talked about it earlier.
Yeah. Good. All right.
But
Cool. Thank you. Mr. Kondaris, what am I doing right now? Abducting. Thank you. Abducting. Thank you, sir. Miss Jaundice, what muscle is responsible for this up to about this point at least?
Your deltoid?
My deltoid. Thank you. And probably my whole deltoid, actually. Mainly the middle, but probably the whole darn thing is grabbing. All the stuff is grabbing to pull it up. Yeah. All right. Miss Monreal, this one's tricky. I'm already up here, and believe it or not, what's happening is my deltoid actually is trying to lift up higher, but I'm kind of hitting this bone, this acromion process. So now what needs to happen to get my arm up higher is something like this. So what is happening to my scapula here? Do you know what's happening to my scapula here?
Rotation of the scapula.
Yeah, did you say upper rotation of the scapula?
Rotation of the scapula.
Yeah, upper rotation of the scapula, but you were right.
I said rotation, and then I was going to ask you specifically how do we label that?
Yeah, You label it by looking at the acromion process. If it's going up, it's an upward rotation. And the good news is, by the way, when my arm's going up, I'm doing an upward rotation. There's nothing weird. And when it's going down, I'm doing a downward rotation. Cool. Cool, cool, cool. Miss Torres, what muscle can actually create an upward rotation of my scapula?
Your latissimus dorsi?
Well, is my latissimus dorsi on top of my scapula so it can pull it?
What?
You can't pull something up unless you're on top of it. If I want to lift this pen up, if I can only pull, I've got to be on top of it. Is latissimus dorsi on top of my scapula? Is it above it?
No.
What's above it?
The upper trapezius.
Yeah! Okay, thank you, ma'am. Miss Hanson. Now let's put this together. What two muscles are doing this?
Deltoid and upper trapezius.
Yeah, 100% correct. Yep. Theoretically, the deltoid's going to about here, and now the deltoid's staying contracted and stuff, and the trapezius is taking it the rest of the way. Yeah. Very, very good. Very, very good. Cool. Miss Harper. Miss Harper. Miss Harper, what action am I performing right now? I'm adding it back to my midline. Yes, horizontal adduction, adduction. Beautiful, thank you. Miss Hunter, of the four muscles we've just learned about, which one is helping me do this?
The traps?
Are the traps in...
Your biceps?
We haven't learned about biceps yet, hold on, that was cute. Are my traps in front of my body?
Sorry, can you repeat that?
So here's the thing, I'm trying to lead you a little bit here, but I'm moving my arms in front of my body, right? Muscles can only do one thing, pull. They can only pull or contract. So I need a muscle in front of my body to do it. Are my traps in front of my body?
No.
They're behind my body. They tend to do stuff back here or up there or whatever. So what's in front of my body that could be doing this adduction that we learned about, the four muscles we learned about?
Oh my god. That one, I thought that was the anterior something.
Starts with a D.
Fiber.
Anterior.
Anterior deltoid.
Yeah, bam. You guys, I honestly can't tell you how phenomenal you're doing. I could care less if you've memorized this. I'm much more interested in what Miss Hunter just did. Visually putting it together and matching it back up in her head. It'll make you great later. Because it means you can actually think about kinesiology. Fantastic. Thank you, ma'am. Thank you, thank you, thank you. Miss Felix Osuna. I am rolling my shoulders in. I'm rolling my glenohumeral joint in. My scapula is not moving. I'm rolling my shoulder in. What do we call that movement where my shoulders roll in?
Medial rotation?
Medial rotation. Thank you. All right. Miss Stanley, I've got a really hard question for you. It really is hard. Of the muscles we've learned about, and there are several, which ones are helping me do a medial rotation? Which ones are helping me do a medial rotation?
Isn't it the deltoid and the trapezius?
So trapezius doesn't grab on the arm, so it can't be that one. But the anterior deltoid grabs in front so it can roll in front. Is there any other thing that grabs in front even if it's in back, but it grabs in front?
The Latissimus dorsi?
Yes! And anytime I say Latissimus dorsi, you say what? Yes. Yes. So if the answer is Latissimus dorsi, the answer is always Teres Major too. So I know those muscles live in back, but they grab in front. They grab in front, and so they can roll my shoulders in. Yes, very good. Very hard question. So we have learned 3 muscles that actually aid in a medial rotation right now. The anterior fibers of the front deltoid. I just said anterior twice. The anterior deltoid can roll me in. And the traps and the Teres Major both reach underneath my arm and grab in front, so they can roll me in too. They can all do a medial rotation. Miss Cooper, I am rolling my shoulders back. I'm rolling them out. What do we call that action?
Moving like this.
Not moving the scapula. I'm just rotating. It's a rotation. What kind of rotation is this when I roll my shoulders out?
That would be a...
It's not medial.
It's not medial.
So what's the opposite of medial?
Medial would be lateral.
Yes. It's a lateral rotation all day long. Thank you very much. Thank you, thank you. Cool. Okay. Miss Petrie. Which of the 4 muscles we learned about, only one so far helps me do a lateral rotation? Where I roll my arms back. What muscle would help me roll my arms back? A lateral rotation of the 4 we've learned about.
I'm stumped.
That's okay. You're allowed to be. So, would this muscle be found on the front or back of my body?
Well, I feel like it's the posterior.
Posterior what?
Deltoid, but I'm stumped.
Why don't you say posterior deltoid? Just try it. Just see what I say back.
Posterior deltoid.
You're exactly right, Miss Petrie. That's absolutely fantastic. Of course, it's posterior deltoid because when I roll my shoulders back, I'm rolling it back behind me, which means it has to be a muscle behind me that's pulling the shoulders back, and the posterior deltoid right here, this red thing right here, when you pull it, that arm comes back. You are 100% correct. Yes, thank you. You guys got this. Let's take a 5-minute break before we launch into new material, okay? Because we have to talk about the skin today, but I think that is enough of this. We will come back to this. So if you love it, we'll get to do more of it. If you hate it, we'll get to do more of it. But we will come back to it. But take a 5-minute break so you can wash this out of your brain before we kind of introduce something completely different. 5 minutes, everybody. Let go of all the stuff we just did. It won't disappear from your brains. It'll still be there later. We're going to come back to it and reinforce it. This is a very common teaching technique, by the way, where you switch back and forth between material and let it kind of percolate and simmer over here in this part of your brain, and then introduce something new and then come back to it and go back and forth. We actually find one of the problems that happens in education of any kind. What page is page 555, 555. One of the things we find that happens in all types of education is your brain shuts off after a little while. And I don't just mean yours, mine, everybody. It doesn't matter how good a student you are. Your brain shuts off, and so switching back and forth between material tends to keep your brain going. Yeah? Okay. We are going to talk about, let me present my slide. We're going to talk about something called the integumentary system. And I will explain what the integumentary system is here. Again, you're always welcome to ask questions and all that good stuff. Just don't ask what the integumentary system is, because I'm about to tell you. Again, I think it's important that you're familiar with this material. Familiar. It's not like you have to live and breathe it, right? I just want you to be aware. But I don't want you to look like an idiot when you're working someplace and somebody's like, well, that's the integumentary system. You're like, the what? We want you to know what it means. Yeah? So I want to go back. That's not what I wanted. Hey. Hold on, I want to make sure this is the slide that I wanted. All right. Well, it's missing one of the slides I want. Let me frame this discussion. I think it's very important. You have a filing system in your head, whether you know it or not. It's very important to know where to put files, right? Remember, one of the ways we understand the human body is we look at systems of the body, right? One of the systems that we were just in and working on was the muscular system. Remember, that's all your skeletal muscles and your cardiac muscle and your smooth muscle. That's the muscular system. This skeleton is made out of the skeletal system, right? The nervous system was all the wires. Today, we're going to talk about a system called the integumentary system. The integumentary system. And the integumentary system is essentially your skin and all the associated stuff with it. They call it the associated appendages. But let me put it in a much simpler term. It is your skin, the glands that are in your skin, which to me is still your skin, your hair, and your nails. Skin, hair, and nails. Yeah? That is literally what, so when you hear integumentary system, I want you to think skin. I really do. Your integumentary system. It's actually a really important system in your body, and it kind of weaves into other systems of your body. And for massage therapists, by the way, it should be super important because you're going to be touching people's integumentary system, right? Yes, we are. Yes, we are. And their muscles are found underneath their integumentary system. In fact, one of the things that makes your job hard is you have to imagine and find muscles underneath the integumentary system. You can't peel back their skin. That is a different type of medical professional. That is a surgeon, and you are not. The good news is everybody leaves better when they come to see you. So the skin is the largest organ in your body. It is actually considered an organ. It's considered an organ because it's a whole lot of like tissue together. You know, it's a whole lot of, I'm sorry, I said that wrong. It's a whole lot of like cells together, a whole bunch of skin cells together, which make it skin. And it's the largest organ in your body. And it does all sorts of amazing things for you. Right? One of the big important things it does is that it holds all the juices in here that I need inside, and it keeps them all inside. It's a giant sack. It is a giant sack that keeps all my stuff inside here and separate from the rest of the world. It is a protective barrier, right? Just like the cell had a protective barrier, right? Anybody remember the protective barrier the cell's called? It's called the cell
Membrane.
Cell membrane, thank you. So my cell membrane is my skin. Yeah, it's my skin. Yes, we are just walking giant sacks. You really are, Ms. Cooper. And you're also a giant walking sack of chemistry that has to stay balanced. And so every time I drink water, I'm giving my body a chance to eliminate stuff it wants to get rid of or keep stuff it wants to keep, but I'm trying to keep that sack balanced. If it becomes out of balance, you die, actually. So you really are a big walking sack. You're actually...
Homeostasis?
That is homeostasis. Your body is always trying to stay in homeostasis to keep you alive. Exactly. Well said. Okay. So, skin helps with protecting you against the outside world. Part of that is your immunity. So your skin is part of another system. So it is your own system, your integumentary system. Remember how I said they all feed together? It's really hard to separate one from the other because we separate them to understand them and learn about them, but they really all go together. It's part of my immune system, right? If you have a client that has a cut on their back and you have a cut on your hand, should you rub those two cuts together? No! Yes. However, in general, this isn't 100% true, but it's close. If your client has no cuts and you have no cuts, you can probably rub stuff together all day long and not worry about catching anything as long as you wash your hands afterwards. Yeah. Chapter 22, page 555. So, Your skin also, by the way, absorbs things. So just remember that. It can absorb things. It acts as a barrier, but there are some things that can go through your skin. And that's why when you use massage oils, I like to use massage oils that are made up of things that I would eat. So, like coconut oil, for example, is something that I would ingest. So rubbing it on my skin doesn't worry me, right? But I probably wouldn't put mineral oil on my skin because it's made out of petroleum and stuff, and I'm not going to go drinking motor oil, right? So it just makes sense because your skin can absorb things. Another wonderful thing your skin does, and this is super duper important if you're a massage therapist, gives you your sensation. Your sense of touch is in your skin. Super important. You wouldn't be a very good massage therapist if you didn't have a good sense of touch. You wouldn't know when you were poking through somebody's body or touching them too lightly. A big one is temperature regulation. My skin helps me regulate my temperature. And they call this thermoregulation. Thermo just means temperature. Thermoregulation. My skin does that in a variety of ways, but one of the things that are just very simple to kind of visualize is, if it's very cold in here, my skin actually contracts the blood vessels around my skin and keeps my blood inside. If I'm too hot and such, my blood vessels will open up close to my skin and get rid of that heat and radiate it off. So that's why sometimes your skin is hot or cold. It's your body trying to regulate your internal temperature. It's totally cool for your skin to be hot or cold. It doesn't matter. It's your body trying to get rid of heat or trying to keep heat in, depending on what you need best. Yeah? What's one of the other things that you notice that you do for temperature regulation that's due to your skin when you're outside and it's hot and there's this water all over your body? That water is you sweating. Sweat. And that sweat is actually water coming through your skin on purpose. It evaporates, and that evaporation process actually cools down your skin and thus your whole body. You're an evaporative cooler. Some of you have evaporative coolers on your house. So that's another way that you do thermoregulation. You also excrete stuff through your skin. So your skin actually dumps stuff out. If you've ever been out, I know that nobody in this group would ever do anything like this, but if you'd ever had too much to drink, sometimes you can smell it on your skin the next day in your sweat and such, because about 2% of the alcohol that you drink actually comes out through your skin. But other products can come out through your skin too. If you go to a foreign country, you will notice that people smell different. They're not dirty. They eat different food than you do, and those herbs and spices actually come out through their skin. And so that's part of the way you're smelling it. They think the same thing about us when they come here. So that's very, very normal. And last but not least, your skin actually helps you produce vitamin D. It needs the help of something to help you produce vitamin D, something that we almost get too much of in Arizona. What does my skin need to make vitamin D?
The sun.
The sun. With the help of the sun.
I have a question.
Yeah.
And this is a little bit off the subject, but
That's
why
okay.
do old people smell the way they smell?
Well, it depends.
I'm sorry because that's rude, but it just is
All right, well, let me smell.
what it is.
So,
You're no.
all right, so it's a two-part answer. One is, when we talk about old people smell, it's kind of a cultural thing, right? And we are lumping a whole lot of stuff into one thing. It's not that all old people smell, because I know lots of old people that don't have a particular smell. So some of it is all the medicinal stuff they're using, right? Or whatever products they're using and things like that. They're getting marketed to that group so that you kind of think of that as an old person smell. The other thing, though, can be deterioration. So your skin is something that you can smell infection and deterioration coming through. So if they're very old, unfortunately, when people are getting ready to die, that is a scent that you can actually pick up. In fact, there are some dogs out there that can actually smell when you have cancer. They're really finely tuned sense of smell. But so in theory, when people are getting very old, they are starting to degenerate. and you are smelling some of the breakdown of their body. Yeah, if it's an unpleasant smell, that's what you're smelling. The other stuff is just the fact that your grandmother wears cheap perfume, like my grandmother, and I'll never forget the smell of it.
Yeah, I have a question.
Yes.
Yeah, how about the Arizona having the air? I think air the makes skin dry.
It can, absolutely.
Yeah, and sometimes you talk about the old people, right? I think sometimes about the first time in the when old and people don't have something mean clothing and everything. What about that?
Yeah, that's actually really brilliant. Thank you, Ms. Nguyen. So if I understood you correctly, and I think I did, what she's describing is that when people get older, they secrete less oil on their skin. You guys have natural oil secreting glands that we're going to talk about actually in this lecture. And as you get older, their skin gets drier and they secrete less oil on their skin. And so dry skin has a little bit of a smell to it too. It's dead skin, by the way. Your top layer of skin on all of you is dead. All of you. That's why you can scratch your skin with your nail like this and you don't bleed right away, right? You just get some skin underneath your nail. Most of the dust in your house is your skin. Almost all of it. But you're absolutely right, Ms. Nguyen. Dry skin. Yeah. We will talk about collagen, yes. Lack of collagen.
Okay, I kind of have a question too.
Yeah, yes, please.
So when you massage someone who's like elderly, their skin is a lot thinner, right?
Yes,
so you have to be more careful if you're massaging someone who's older.
Ms. Jaundice, thank you for bringing this up because I didn't put it in my lecture today and I don't know why and I really should have. It's a super important thing you brought up, so thank you. Yes, the answer is just simply yes. A lot of people worry about working on somebody who's 50 or 80 or 90. I could care less what your age is. I kind of care what your skin age is, right? So I've had 90-year-old people come skipping on in and you grab their skin and it's still kind of rubbery and bounces back and there's some meat to it. I work on them basically the way I would work on somebody who's 40, right? I don't really consider that to be a bigger deal. This person seems healthy, all that kind of stuff. But if they're showing signs of their skin being thin, you're absolutely right. It gets thinner. They have less thickness to their skin. You can tear their skin. So one of the solutions is two things, by the way. They can bruise easier too. But you use more oil. So normally I'm like, don't use oil. Use 2 drops. Stop using so much oil. Guys, why are you using so much oil? Because I want you to get traction. On an old person, I'd be like, use lots of oil. Yep, and I shouldn't say an old person. I should say a person with old skin. Because you honestly will have 90-year-old clients that are super healthy and you'll have 30-year-old clients where you're like, this guy's going to die. Like, what's the matter with him? But you're right. As people get much older, their skin usually thins. And when you're feeling that papery, thin skin, you can feel it. Yes, use more oil and less pressure. Both. But more oil so you don't catch the skin. Yeah, great question. I don't know why I didn't include it. I'm really glad you did. So thank you. Thank you very much. Okay, so remember we touched on skin earlier, right? We've tried to touch on each system of the body earlier, and now we're deep diving into one system, and we're going to deep dive into another system. So when we talked about skin earlier, we said it had 3 layers. We said skin had 3 layers. We said it had an epidermis, which is the top skin up here, epidermis, and then a dermis, and then a subcutaneous layer or a superficial fascial layer, right? So epidermis, dermis, hypodermis, epidermis, dermis, subcutaneous, epidermis, dermis, superficial fascia. There's actually 3 names for the last layer. We're going to get to that, but I'm going to talk to you about the epidermis first. I just want to let you know we're talking about the top of the skin right now. We're talking about the top of the skin, then we're going to talk about the dermis, and then we're going to talk about the hypodermis or subcutaneous layer or superficial fascial layer. They're all the same thing. And I just want you to kind of understand some general things. So the epidermis is the outer region of your body. It's the stuff on top. Yep. It's composed of epithelial cells. Do you remember when we learned that there are 4 types of tissue in your body? And we said there's muscular tissue, nervous tissue, skeletal tissue, and epithelial tissue. This is epithelial tissue was the one that coats the outsides and insides of things. So the insides of your throat, outsides of your body, everything. So that's all that means. Don't overthink it, right? This is important though. The top of your skin is relatively avascular. A is a Latin prefix that means not. Vascular means blood, not blood. There is not a lot of blood going to the top of your skin, which is good because that way you don't bleed every time you walk by something and scrape on it. But it also means the top of your skin's not getting blood, and things that don't get blood do what?
Die.
They die. And the top of your skin is dead. It is dead. Sorry, it's dead. But that's good. It's good that it's dead because it protects the alive skin underneath. So, not to make this too confusing, but we have an epidermis, a dermis, and a hypodermis, or a subcutaneous layer, or a superficial fascial layer. Of this epidermis up here, there are 5 layers to the epidermis. And I'm about to talk to them from most superficial to deepest. So most superficial will be the top layer. So touch your arm right now, or touch your face, touch your tummy, whatever you want to touch. You are touching the stratum corneum layer. You are touching the stratum corneum layer. And I tried to make this very simple for you guys actually. I put dead next to it because the cells are dead. It's a good thing, but they're dead. So you just touched your dead stratum corneum layer. Then, if you went under that layer, on your bottom of your hand, on the palms of your hands or the bottom of your feet, you would find this next layer. This is called the stratum lucidum. Stratum lucidum. This layer is only found on your hands and feet. It's an extra layer of thickness because your hands and feet get lots of wear and tear. It's this translucent clear. It's this clear layer that's found on your hands and feet only. So you don't have 5 layers everywhere. You only got 5 layers in your hands and feet. Then you've got what a lot of people call the granular layer, which is the stratum granulosum. Then you've got the stratum spinosum. Don't worry, you don't have to memorize all these. Which is the spiny layer. And then the stratum basal. The basal layer is actually really important. The basal layer actually creates a lot of your keratinocytes, which are keratin cells, and we're going to talk about those in a minute. So you got 5 layers. And what your skin does, by the way, is it very much grows from the bottom up. And our estheticians here know this. They like to take chemicals and scrubs and mechanically or chemically remove the top layer of your skin, get rid of the stratum corneum. They want to get rid of that stuff. They go deeper than that because they want new dermis to grow new skin cells so that you've got alive, younger skin cells on top because it makes your skin look better. So they speed that process up by scraping stuff off the top, and your body's smart. Your body goes, oh, we're missing some skin, let's grow more. Boom. Okay. So, there are several coloring agents in your skin, and one of them is melanin. Melanin is actually really helpful. It protects you from sunlight, right? And if you came from a place, if your heritage is coming from a place with lots of sun, you probably have lots of melanin to protect you from the sun. If you came from a very cold place without lots of sun like my ancestors did, you have very little melanin in your skin because my skin wants all the sunlight it can possibly get, so it can make vitamin D. The problem is, now I live in Arizona and I don't have much melanin. So I have very little natural protection to sun. But melanin is one of the things that gives your skin dark color. It's one of the things that protects you from UV light, ultraviolet light. It is also strangely found in your hair and in your eyes. Not the whites of your eyes, but the colored part and the black part of your eyes. It's just good to know about it. Okay. Keratinocytes. I said I'd talk about this. These make up 90% of your skin, and they're what gives strength to your skin. Keratinocytes are cells that give strength to your skin, and they grow and kind of move up the layers of your skin, and they're what gives strength to your skin. And when they mix with skin oil that you make too, they get kind of wet and they actually create a waterproofing barrier for you. They're part of what waterproofs you. In fact, when you put lotion on your skin, you're just lotioning up dead keratinocytes and making them soft feeling. You haven't really made them better. You've just put more oil in them and lubed them up even more so they feel soft. If you went and rubbed oil on a paper bag, it would feel soft too. Brown paper bag. And that's kind of what you're doing to your skin. Nothing wrong with it either, I'm not saying that, but you're just putting more waterproofing agent on it, and it's soaking that up because that's what it's designed to do. And it feels softer to you, and it is softer, but it's just as dead as it's always been. Skipping through stuff. These are all the layers. Beautiful picture of skin here. We might come back to this in a second. Okay, so we talked about the epidermis. We talked about the 5 layers of the epidermis very briefly. I totally admit very briefly, but it's because I want to spend the majority of the time in our course talking about muscles and all the really difficult stuff, right? So anyway, now we are down to the dermis, right? The dermis is actually the thick part of your skin. Some people call it the true skin. It's the real skin. It's not the stuff that's slowly dying on top that's protecting the dermis. It's the true skin. It's the thick part. Yep. So dermis and true skin are often used together. It's got collagen and elastin in it. And that stuff is really amazing and really important. So elastin should sound like elastic, and that's what it is. It's kind of tiny, I know it's not really this, okay, but it's like tiny little microscopic rubber bands in your skin. And collagen is like tiny little steel wires in your skin. In fact, collagen, pound for pound, it's microscopic by the way, but pound for pound, it's stronger than steel. And collagen is really prevalent, especially in young people. Young people have lots of collagen and lots of elastin, which is why your wonderful faces snap back so beautifully. As we get older and we get less collagen and elastin, we don't have as much strength and elasticity to kind of bounce our faces back, so they start to sag down here. The other thing you have in your, oh, go ahead.
Keep collagen.
What?
How does a person keep skin looking young?
So one half of your question needs to be answered by an esthetician offline, and because I don't know. The other half I will tell you is nutrition. Yeah, sunscreen's a good one too, but nutrition. Your skin is actually getting what it needs mainly from inside your body, and so nutrition really has a lot to do with how healthy your skin is. And by the way, so does genetics, and so does, stress levels, and so do all sorts of things. But yeah. What you put on your skin and what you put inside your body seem to have a lot to do with that. You also have dendritic cells. And these cells are part of your immune system. They help to warn you when something is getting inside your skin. They actually kick off your immune system. And they're little cells that look out for stuff getting into your skin that might be harmful to you. Okay. So, 70% of the dermis is this collagen stuff that we were just talking about. The collagen stuff is the stuff that's stronger than steel. It's tiny little fibers, and it helps, by the way, give support to your skin so it's not too mushy, and so it's strong, and so it doesn't tear. And so blood vessels running through it and stuff like that don't collapse. It's like the steel girders on a microscopic level. It's like the steel girders of your skin. And collagen makes up 70% of your dermis, and it is the steel strength of your skin. Elastin, remember again, elastin is what gives it the stretch. So think about this, kind of brilliant what Mother Nature did. Your skin, and this is true of fascia too, because fascia and skin are very similar. Your skin has collagen and elastin, so it's got stuff that makes it strong, but it's also flexible. So it's like if you made Jell-O, but you put a whole bunch of steel wires in it and rubber bands. You'd have this very pliable Jell-O, but it would be strong and rubbery. And that's what we're looking for in skin. Because your body, by the way, is always dealing with something very challenging. Your body needs to be very rigid at times and very elastic at times. I want to be very elastic when I get in a car accident, or somebody punches me, or when I fall down. I want to bounce. I want to be very rigid when I pick something up. I don't want my bones to bend. I want my muscles to pull on them, and I want everything to stay where it is. So to be very strong, I need to be rigid. But to protect myself, I actually need to be very elastic. And so my body is always trying to deal with that formula. That formula of how do I make a very elastic person, a very rubbery person, but also a very hard person that can lift stuff and do things. And when you're a kid, you're more elastic. And as you get older, you get harder. And the advantage of that is when you're a kid, you tend to bounce off things. And the advantage of when you're older is you tend to be able to pick up kids because your bones are formed and I can carry stuff around and you're much stronger, not just because of your size, but because of your rigidity. Your levers are stronger. Yeah. Okay, so we talked about the epidermis. It had 5 layers. We talked a little bit about the dermis. It's got a whole bunch of elastin and collagen in it. Makes it strong and rubbery, right? 70% collagen. Now we're going to talk about the 3rd layer, which is the subcutaneous layer. Sub means under. Cutaneous is skin, really. Subcutaneous, under the skin layer. Or hypodermis, because hypo means under. Hyper is above, hypo is under. So hypodermis, subcutaneous, hypodermis, or superficial fascia. Superficial means above, but we mean above all the other fascia that's underneath here. So the highest layer of fascia is the lowest layer of skin. So this is the subcutaneous layer. It's deep to the dermis, obviously. Also called hypodermis and superficial fascia. And if it goes really deep in between the muscles, we call it deep fascia, because you have fascia wrapping around all your muscles too. You might have seen it in a steak. If you cut a steak crosswise, sometimes you'll see kind of marbling running through it. That's actually fascia. It's actually deep fascia. This layer consists of loose connective tissue, so it's connective tissue mainly. Adipose tissue. What's adipose tissue?
Fat.
Fat. This is where I carry a lot of my fat. You can carry fat inside muscles and things like that, but this is where we carry a lot of our fat. This is a good place to carry fat because it actually acts as insulation for your body, and you need some insulation. Yeah. Your nerves are in this area, and blood vessels, which is super important because they're feeding the dermis. Blood is life. Blood is life. Blood is life. We talked a little bit about skin color. There are some skin color things that you'll run across as a massage therapist. Like I actually have a friend who has albinoism. Albinoism means that my friend does not produce any melanin at all. And there's absolutely nothing, I mean, there is something wrong with this. This person cannot even get out in the sunlight even for a second. But can you massage a person with albinoism? Absolutely. There's no precautions whatsoever. That's why we bring it up. You'll also sometimes see a condition called vitiligo, which is partial loss of pigmentation. People have splotches where they're missing pigmentation. So they got brown and then white splotches where it just seems like they didn't get colored in there. Nothing wrong with that whatsoever either. You can massage that person all day long. There's nothing wrong with it. I wouldn't even mention this stuff to a client, right? People already feel super self-conscious coming in to see you. And the last thing you want to do is be like, what's that, if you don't need to? If you don't need to. These are just colorations within the skin. Yeah. There's also something called hyperpigmentation that we sometimes see with pregnancy due to the hormones. Hyperpigmentation is actually when you get areas that get darker due to hormones and such like that. The linea nigra is a dark line that sometimes appears on some women when they're pregnant right down through their abdominal area. And it has to do with the stretch of the tissue there and also the hormones that are associated with that. And it gets really dark during that time. Again, it's not a concern. It's just to make you aware of some of this stuff. So melanin gives you this brown or black effect in your skin. Carotene, like carrots, gives you this yellow look to your skin. In fact, in theory, you could eat enough carrots to actually show more yellow in your skin. Carotene really is found in carrots too, and you really could eat a lot of carrots and probably see more yellow in your skin. Like it's a pigment you can pick up from eating too. Yeah. Asian people tend to have very little melanin and lots of keratin, right? And so they do have a slightly yellowish color. That's just the way we're all made. We all have different amounts of keratin, melanin, those kind of things in there. It's just good to know. If we say somebody is looking jaundice, that means we think that their skin looks yellowish and not like this mild kind of keratin kind of yellowish. It often is a sign that there's a liver problem or something. And jaundice is not a healthy sign. If somebody really comes in to you and you're like, wow, they look yellow, like I have not seen somebody like this before, that can be a sign of liver problems, actually. Jaundice. Cool. Let's talk about some other terms here, too, that you will hear as a massage therapist. Hyperemia. Believe it or not, this is a term, this is something we shoot for in massage therapy. You might have heard Mr. Ibarra say this word before, hyperemia. Did you? Has he said this yet? No. Okay. Well, you can impress him today. When you are rubbing somebody, one of the things that happens is you get vasodilation, which means their blood vessels dilate. Vasodilation. They open up. And what happens when our blood vessels open up near the skin? We get red. Right? So in massage, hyperemia is a good thing. I want to rub your skin until it's red. I mean, I don't want you to be irritated and I don't want to hurt you, but I want hyperemia. It means I'm bringing blood to the area. So hyperemia is something that's a good thing in massage. We are trying to create hyperemia. We're trying to create vasodilation. We want the blood vessels to open up and increase blood flow. But you also see hyperemia when Mr. Tapscott makes a mistake and I get embarrassed and then my face turns red. That's hyperemia too. But in massage, I'm trying to do it because I'm stimulating the area. That's hyperemia. That's a good thing from a massage therapist's point of view. Cyanosis is not a good thing. Cyan, blue, cyanosis is not a good thing. If somebody looks blue or purple, what could be going on with them? Don't overthink it.
They're not breathing?
Yeah, they're not getting oxygen. They're not getting enough oxygen, especially if they're blue underneath their nails. Yeah, if somebody's looking that way and they're still upright or whatever, that person's not getting enough oxygen, and it's a pretty serious situation. I would not be massaging them. So if somebody comes to you and looks even a little bit like a Smurf, think about calling 911. They're not getting enough oxygen in their blood for some reason. Yeah, if they're passed out and they look blue, you better call 911. Fast. Fast, fast, fast. That's super, super serious. So cyanosis is not a good thing. Blue is not a good look. It's great in your clothing line, but not in your skin. And pallor means pale skin, and that can also be a sign of low oxygen too. So, you'll sometimes if people get really scared, right? They have an extreme drop in blood pressure and they turn pale. In fact, if you ever see a client get up off a table and all of a sudden they go pale, grab them. They're about to pass out on you. And by grab them, I don't mean nicely. There's not time. I mean, if their hair is the only thing available, I'm grabbing it. Because I want to prevent that head from hitting the floor. Right? This is actually one of the main things I worry about in massage. Massage is extremely safe. Massage is extremely safe. Most clients get hurt because they fall down. It has nothing to do with the massage. And when you get up from a massage, your blood pressure can change very rapidly. And so if somebody gets up and they do one of these, you see that, you start grabbing stuff. You're not even trying to keep them up. You're trying to make sure they don't fall down hard. Right? I don't care what it does. I'm grabbing that hair that's going by me, and I'm grabbing and slowing down their fall. That's why I always tell clients, please get up slowly. It's normal to feel lightheaded after your massage. Please get up slowly. Right? So anyway, when you see sudden pallor, that person might be getting ready to pass out. Be ready. This is not to scare you, by the way. I've done something like 10,000 massages, 15,000 massages, and I don't remember ever having a problem. But still, the problems that you will have are not like crazy ones. They're more like somebody gets up and they pass out or something because of blood pressure changing too quickly or something. All right. And you should know what ischemia is. Ischemia is the opposite of hyperemia. So hyperemia was lots of blood. Ischemia gives that pallor color. It's very little blood. So hyperemia in massage is kind of good because we're getting blood flow. Ischemia is blood being cut off. If you cut off blood to something too long, it dies. That's ischemia. Boom. Hair. Let's see. What do I want to say about hair? I mean, it's made out of the same stuff your skin is. Keratin cells, really. Keratinocytes. It does come through little hair follicles in your dermis. And we're going to find out that there's a muscle attached to every single hair on your body. On your skin, all those little hairs. And that's why a little fly can land on like one little hair in your skin and you can feel it. There's a muscle and a nerve attached to every single hair follicle. In fact, the muscle is called the erector pili because it actually can lift the hair up a little bit, like when you get goosebumps. And there's a nerve going to it too. Your book says the function of hair is to protect the skin and the body orifices. I'm not sure that's 100% true. The hair on your head is really important because it keeps your head warm. And believe it or not, when it's cold, about 80% of your heat loss comes through your brain. There's a tremendous amount of blood going up here. And a lot of heat gets lost through your head. And by the way, if you're overheating, a lot of heat can come in from the sun too. So hats are very good for two different reasons. But so hair up here probably really helps with temperature regulation. In other areas of your body, the hair you get when you go through puberty, we're not sure if that's for skin protection or, believe it or not, to hold scent to your body. So to hold pheromones into your body, and that hair might serve a purpose, like a mating purpose, like to hold a scent that somebody else can recognize. We're not so different than animals, and so so that might be the other reason for hair. So your smelly armpits, by the way, hair in there helps hold that smell in there, and we have been trained that smell is a bad thing, but from an animal point of view, smell is a way to recognize another person. Yeah, and there's some fascinating studies done on this, by the way, where very interestingly, if you smell the sweat of like family members, you usually find it actually distasteful. And it's one of your body's ways of recognizing that that is a person with too close of genetics to you to mate with. And people from a very different genetic background tend to have more favorable scents to you, which allows you to kind of differentiate. Yeah. You ever been in love with somebody, you're like, oh, I just love the way they smell, you know? Yeah, it is funny. Anyway, erector pili, I just talked about this. All it is little muscle that attaches to a hair and helps erect the hair. Erect the hair when you get cold. Erector pili. That's it. Comes up when you get cold or scared sometimes. You can also get that goosebumps, that dimpling in your skin. That's all from the erector pili pulling on the skin. On the hair that's in the skin. Well, let's see. Nails. So, there's not much to know about nails except two things here, really. Maybe three things. The root of your nail is where all the nail gets produced, and then it gets pushed out as it's coming up here. It's done growing up here. It's always growing down here at the root, right? And then you've got this cuticle growing over it to kind of protect it and nourish it. But the more important thing to know about nails is, why do massage therapists keep their nails very, very short? Not very short, very, very short. What was that, Miss Bilateral? Sorry, I called on you because you mouthed something and...
Scratching them? Like scratching them?
Yes, yes. So...
Also for like sanitary reasons.
Thank you.
Both. I have an answer. Oh.
Yeah. Both those are correct. Do you have more, Miss Monreal?
Yeah, because you can feel with the tips of your fingers better if your nails are short.
Oh,
if they're longer, you're not actually being able to use.
Wow. I love all three of these answers. Thank you. I'm glad you, yes. So yes, one is scratching a client. Believe it or not, people hate nitpicky little feelings, right? Like me personally, I'd rather you punch my arm than just poke, 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 right? And little bits of nail are really annoying. They scratch clients. Most people don't like that. That's one reason. Another reason is every time I scratch somebody, I pick up their cells and I carry them around with me now. And I can scratch them underneath somebody else's skin. And that's not a very cool thing to do. I've now transported something to another person. And Miss Monreal makes an excellent point about the tips of my fingertips being sensitive, and I can't feel the tips of my fingertips if fingernails are pushing out over them. Yeah. I'm always really suspicious when I see a massage therapist with fingernails that I can see. I'm like, is this person a good therapist? Because I just, yeah. Get used to cutting them short now, because when you first start cutting them short, by the way, your fingertips hurt. Because they're not used to having stuff hit them all the time. So start cutting them short now. I always tell students, if you've cut them so short they're bleeding, that might be short enough. It's a joke, but I almost mean it. Okay. So there's the nail root, where it's forming. The cuticle is the skin over there, and the free edge is something that you will never have because you will cut it off, all of it. Okay. So let's talk about glands in your skin. Glands in your skin. You have oil glands and sweat glands, essentially, in your skin. You have two main types of glands in your skin. Sebaceous glands produce sebum, and sebum is oil. Sebaceous glands produce sebum, and sebum is oil. It's actually really good oil. It's the oil your body produces to lubricate your skin and keep it waterproofed and keep it healthy. And so this might kind of sound gross, but sometimes if you're working on somebody and you're not using oil, you will be squeezing some of the sebum out in their skin, and you'll start to notice their skin gets kind of oily after a while. That's their sebum. That's their skin oil coming out, which technically is a good thing. But so sebaceous glands make sebum, which is oil, which is meant to oil up your skin, your keratinocytes, so that you stay waterproof and all that stuff stays sealed together and that you have a good barrier protection. That's the point. So sometimes with massage products, you'll see these products saying, this massage oil closely replicates the own sebum of your body. And they're trying to tell you that they've got a product that is very similar to the oil you produce. They say that about like jojoba. They say it's very similar to the sebum that your body produces. I actually have no idea if that's true. That's just one of the things they say. All right. Then you've got sweat glands. Sudoriferous. Sudoriferous glands are sweat glands. Sudoriferous glands are the glands that make the water. Sudoriferous glands are sweat glands. And you've got eccrine and apocrine. Epcrine, some people say epcrine, but I was always taught epcrine, are the sweat you're used to. It's very watery sweat, tastes a little bit like salt, and it's the cooling sweat. It's the sweat that cools you down. That's eccrine or eccrine. Sweat glands. And they cool you down. You need them. In fact, people that don't sweat have all sorts of problems. They have to be really careful about getting overheated. Then you've also got apocrine or apocrine sweat glands. And I put smelly sweat glands here to help you remember them. But these are the sweat glands that are in your genitalia area and your armpits. And we think, again, they have a lot to do with scent in those areas. Yes. You also have one other type of gland, but we hardly ever talk about it as massage therapists because we don't touch it. And that's your ceruminous gland. Ceruminous gland. I'm sorry, I never say it because I never talk about it. Which is the glands inside your ear that create your earwax. And you probably shouldn't have your finger inside the client's ear. So there actually is a time that we do it when we work on TMJ, and we'll talk about that. But in general, you should keep your hands on the outside of the body. So sebaceous are oil glands, sudoriferous are sweat glands. And of the sudoriferous, you've got two main types. Eccrine or eccrine, which is the watery sweat, and then apocrine, which is the smelly sweat. Boom. I already told you this. Sebum is oil, right? Lubricates your hair and your epidermis. This is why some people don't wash their hair every day, because they want the oil in their hair. The sudoriferous, the other sweat glands help to regulate your body temperature. We already talked about that, right? They help to evaporate. And when they evaporate, by the way, when things evaporate, they carry heat away with them. That's why it works. Just like an evaporative cooler, if you have one on your house. Evaporative cooler in your house just pours water over a big sponge and blows air through it, and it carries the heat away is essentially what it does. Yep. And the main cooling ones are these eccrine sweat glands. Those are the most numerous. They make what you think of as sweat or perspiration, the watery, salty sweat, that you have. And the apocrine are the ones that we think of as more smelly. So the sebaceous oil glands, these sebaceous oil glands are always associated with a hair follicle. And what that means is that that's where the oil comes out. It comes out on a little hair, on that little hair follicle. Even if you shave the hair, like even if you shave your legs, you still have hair follicles underneath there, and that's where the oil comes out. So 2 important terms to know just because they're common terms used, and they have to do with skin essentially. Hypothermia and hyperthermia. Remember therm or thermo or thermia means temperature, right? A thermometer measures temperature, therm. If I'm super hyper, I've got excess, I'm too much. Hyperthermia is when I got too hot, I've overheated. What you usually hear about is hypothermia. You hear about it especially with athletes that are exercising in cold weather because they're burning off a lot of energy, so they don't have as much energy to keep themselves warm, and they might develop hypothermia, and that's when they get really cold. Hypo is below. And these are good terms to know even if not related to temperature, right? If I have a hyperthyroid, I burn calories really, really well. I can eat whatever I want. If I have a hypothyroid, I might feel more tired and I might put on weight really easily. So we use these terms with other things. So it's really good to know that hyper means exactly what you think it means. Excessive, a lot of, hyperactive. Hypo means below. A hypodermic needle goes below the dermis. That's why a hypodermic needle, it's a needle that I stick in your arm or your leg. It goes below the dermis, hypodermic needle. Cool? Anyway, both those situations are not great. Hypothermia or hypothermia. And you would treat them the way you would think. You would try to warm the one person up and cool the other person down. We already talked about thermoregulation, the fact that your body can regulate your heat by either choosing to give away a lot of heat by putting lots of blood vessels near the skin and giving away a lot of heat, or closing the blood vessels towards the skin so that you are protected from that. And luckily you don't have to think about that. Oh, yeah. Okay. Sorry. I'm looking at my own slide and remembering something I want to talk to you guys about. So your skin is your major receptor. It's the major thing that I use to know I'm not dreaming and interact with the outside world, right? And all my sensations from my skin, go back to my spine through various areas, run up my spine and go into my brain, and they go into an area of your brain called the post-central gyrus. I frankly think after today you'll probably never use the word post-central gyrus again, but at least you'll know what it is if somebody mentions it. You're not ever going to massage it because you're not going to massage somebody's brain. I'm actually telling you about it to make a different point. But it's in your parietal lobe, which is kind of these side lobes here, and so it's kind of in here, your post-central gyrus. And in that area is a section of your brain that is designated just to pick up sensory information. And here's a really good picture. I hope you can see this in the slideshow. But this is about that section of your brain, this post-central gyrus, that has a little map of you. It doesn't really have a map. You can't see it if you open up the head. But the point is, it's about how much of this section is dedicated to different parts of the body. And if you will look at that body mapped out on there, you'll notice that about 80% of this sensing part of your body is dedicated to like hands and arms and face and lips and tongue. That leaves only 20% that's dedicated to my chest, my legs, my feet. 80% goes to this and this. I'm not trying to be weird here at all, but there's a reason we love food so much. Look how much is dedicated to your tongue. There's a reason we like to kiss. Your lips are highly sensitive. Little babies, what do they do with everything? Everything goes in their mouth because this is a huge sensing organ. They're trying to figure out what it is. They love their faces touched. And your hands and your forearms. Thank God your brain has dedicated so much time to this and so much energy to this area because you're going to be using this to touch other people, right? So I only brought all this up because it's kind of interesting. It shows you how much of this area that's meant to take in all your skin sensation is dedicated to just really your face, arms, and hands. 80%. Because your body realizes that's extremely important. When I'm walking around, I have to have enough sensation down there to kind of walk and stuff. But when I get to something and explore it, I have to be able to really explore it. And how important is taste in my mouth and my lips? Extremely important because, by the way, if I'm eating something that doesn't taste right, it could kill me. So all this is very important. Yes. This is why, it's not completely why, but this is part of the reason people have problems with what we call oral fixations, like food, smoking, things, because you get so much sensation from this area of your body. So much of it's programmed into your brain. Yeah, it's kind of cool. But what's also cool is a lot of it's dedicated to your hands, so you're going to be using your hands. You guys are programmed, you are designed to touch. You were made to touch. You were made to connect. That's what we do here. Let's take a 5-minute break before I get into the actual sensory, the nerve engines and stuff, and actually how you feel things. Take a 5-minute break, and then we'll wrap this up. We're close. Cool. 5 minutes, everybody. 10:08. See you back 10:08. So, Merkle discs are, they're tactile discs. That means they actually let you sense touch. They detect light pressure or light touch. Usually, when you're being touched, light pressure or light touch. Merkle discs. They adapt slowly, and here's what that means. You're going to hear a lot about adapt slowly, not adapt slowly, and this is important in massage. They adapt slowly, which means I can touch my skin very lightly, and a Merkle disc keeps sensing that. It takes a long time before the Merkle disc decides, like, I've adapted to this, I'm not going to send a signal anymore. It adapts slowly. Stuff that adapts quickly says, hey, I'm being touched, and then it goes, I'm not paying attention anymore, I'm not even sending a signal anymore. Let me try to say that in a different way. You have nerve sensors that adapt quickly and some that adapt slowly. Ones that adapt quickly, they stop paying attention after a while. They kind of go, okay, I'm being touched, and then they're like, yeah, whatever. My job's done here. They stop sending a signal to the brain, so I stop feeling this. Right? And then you have ones that adapt slowly, like these Merkle discs, and when I touch like this, hours later, it's like, nope, you're still being touched here. Hours later before it tunes that out. You tune out all sorts of stuff, right? Like if you've ever worked at a place that has elevator music that plays all the time, background music, after a while you don't hear it anymore. You've adapted to that sensation. You've just cut it out. You can tune back into it, but you've cut it out. You don't hear it for hours at a time. That's you adapting to it. You just stop paying attention to it. Nerves can do the same thing. Sometimes we want them to adapt to something. We don't want to feel everything all the time. Nociceptors, since they're pain receptors, they're there to protect you. They are there to protect you. That's their job. Because they're there to protect you, they rarely adapt. They don't just shut something out. They're like, this is still a problem, 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 because they're sensing some sharp thing happening and they think it needs to be dealt with. The problem is you'll have clients that have contracted muscles that are pinching on their nociceptors, right? And they're going to be like, my shoulder hurts and it still hurts, right? Because they don't adapt. They keep sending that signal, if there's a problem in your shoulders, there's a problem in your shoulders, there's still a problem in your shoulders. But those are your pain receptors. We already talked about how your hair root has a nerve on it. That's called your hair root plexus. It's just a nerve attached to your hair. Kind of a nerve that wraps around your hair like a little spider's web, but that's not really that important. But it's why your hairs are so sensitive. Okay. Meissner corpuscles detect light pressure, just like the Merkel ones do, but they're very abundant in your fingertips and eyelids and nipples and genitalia. And I'm not trying to be weird here, but these are actually places you do need a lot of sensation. Right? If you're a breastfeeding mom, you actually need a lot of sensation here. And if you're a massage therapist, you need a lot of sensation here. So that's why they're there. And they're very abundant in those areas because you want to be feeling what's going on in those areas. What do I want to tell you about this stuff? I don't really care about Kraus. Kraus corpuscles detect deep pressure, so when you're doing deep tissue on somebody and they can feel that pressure way down in their body, this is one of the things that they can detect. Is this nerve ending will actually tell them like, wow, there's a lot of pressure going deep inside your body, which is an important thing to know, but that's one of their main jobs. And Ruffini corpuscles detect continuous deep pressure. So like when you're being squeezed and such, you feel these a lot in massage too. Yeah. Oh, by the way, I'm sorry. I should have told you this. The Kraus corpuscles, the reason I want to tell you about them is because you'll never touch them as a massage therapist. They're in mucous membrane. So they're sensing something very different inside your body, and you're never actually going to come in contact with them. But you will come in contact with Ruffini corpuscles. You won't actually touch them. You won't know you're in contact with them, but they're the things that your clients are feeling with their deep pressure and such. Sorry, I should have actually made that clearer. And Pacini corpuscles also detect deep pressure. The difference between all these, and please don't even try to memorize the difference between all these because it's just not that important to us. It's important that you know you have nerves in your skin and they can sense how fast you're moving, slow you're moving, how you bend, heat, cold, pain, pressure, vibration. That's it. The difference between a lot of these is that some can sense vibration, some can sense high frequency and low frequency and things like that, and it's just not important to a massage therapist. It's not really important to a lot of people, but the fact is you've got all these different sensors at the end of these wires that send stuff to your brain and say, hey, I'm feeling a deep pressure right now. Or the other one says, I'm feeling a rapid pressure right now. Another one says, we seem to be moving and stretching the tissue a lot right now. Another one says, this is a sharp pressure. This is a nociceptor saying, I think there might be a problem here. They all are at the end of these wires and they all send different signals to the brain, depending on which ones get set off. The deep pressure one's not going to get set off if you're not getting deep pressure. Only the light pressure one's going to get set off. The nociceptor is not going to go off unless something sharp hits it. So they all give your brain a way of being like, what's going on? And your brain literally looks at all those wires coming in this tiny, tiny little area and goes, well, gosh, The nociceptor is not going off, so nothing sharp happening, but the deep receptor is really going off. Maybe we're getting deep tissue right now. It really has to figure that kind of stuff out with how you interact with the outside world. Oh, I'm glad we got to this. All right. So that's just kind of an overview of receptors. And again, I want to just say this one last time. I don't really care about the ends of the receptors. I don't care about all their names or something. I just want you to realize if this was my hand in a spot smaller than that, there are probably 100 of these receptors. 100. If I blew that dot up, there would be hundreds of wires coming back to my brain. At the end of this wire might be a nociceptor. This one might sense deep pressure. This one might sense light pressure. This one might sense high vibration, low vibration, stretch, rapid stretch. If this one gets set off and this one gets set off, my brain goes, oh, well, that's the deep one, the one that means we're getting pressed on really deeply. And this one senses that there's very slow movement happening. I probably don't have to worry about this. This is probably an elbow coming into my back very slowly. Your brain just takes all these different signals, and it's so brilliant, it has to figure out what that means. But if it feels this, and then the nociceptor too, it's like, wow, this is a deep, sharp pressure happening all at once. I wonder if I'm being struck. And it tries to figure that out. Yeah? Miss Hanson, are you doing okay? Okay, you're just holding your head like this, like it hurt. And I was like, I hope I'm not hurting your head.
No, you're fine.
Okay. So I just want you to kind of, I'm really into conceptual learning. Words don't really mean a lot, right? You can always look up nociceptor in a book, but I want you to understand the concept of how it works. Cool? All right. So there are some common skin diseases. And you guys are going to tell us about them. Not right now, don't worry. Don't panic. So, but I would pay attention right now because your name will get called, and you have an assignment for tomorrow, and it's not a hard assignment. But we're going to talk about some skin pathologies. Pathology is the study of disease, right? And so there are things that you will come across as a massage therapist, and tomorrow you're going to let us know what this thing is in simple terms we can all understand. And you're going to let us know if we can massage it or not. If we can massage the person at all, right? Or if we just have to avoid that area, or we shouldn't massage them even a little bit, or whatever. I want to know what it means to me as a massage, what it is and what it means to me as a massage therapist. Remember, if I can massage the person, but I can't massage the area, that's a local contraindication, right? If I have a burn right here, just a tiny little burn, maybe from a cigarette. I don't know why I got a burn from a cigarette, but I got a burn from a cigarette right there. You can still massage my body. You don't have to cancel the appointment. This is a local contraindication, right? If I'm sunburned from head to toe, that might be an absolute contraindication, right? I'm burned everywhere. You might not be able to massage me at all. That might be an absolute contraindication. So I want to know with these, like, are they absolute contraindications or local contraindications? And what are they? So don't worry, you're only going to have to research one of these. And most of the research can be done in your book. But I want it in terms we can all understand. I want it in terms we can all understand. So we don't have to go over acne. Acne is actually an infection of the hair follicle. Usually when the oil in there gets kind of infected in the hair follicle. And acne is a great example of a local contraindication. Can you still massage somebody with acne? Yes, Mr. Tapscott, of course we can, because if I couldn't, half my clients would not get massaged. Yes. Do you rub their acne? Do you actually rub the pimples on their face? No, I don't do that as a massage therapist. Maybe an esthetician I might. Depends on what I'm up to, but not as a massage therapist. It's a local contraindication. Cool? Miss Bilateral will tell us about athlete's foot tomorrow. And Miss Bilateral, there's actually information in your chapter 22 book about athlete's foot tomorrow. Well, the information's today. It's there right now. But the point is, on page, I don't know. On page, I'm on the wrong section.
562.
On page 562, there's information about athlete's foot. It wouldn't hurt you to go on Google, too, and just check out if there's anything else on there, too. But we just want to know basically what it is tomorrow. 5-10 sentences, what it is, and can we massage it? Is it a local contraindication or an absolute contraindication? That's it.
You need that on paper or out of my mouth?
Out of your mouth. You don't need to turn it in. You're going to present to the class like you did just right now, Miss Cooper. Yep. And by presentation, I mean like 3 minutes. I'm not looking for something big. I'm not looking to stress you out. I'm just making you do some of my work for me. I get tired of hearing myself talk. So, Miss Bilotic will do athlete's foot. Miss Bilotic will tell us about athlete's foot. Miss Cooper will inform us about boils. Same assignment, by the way, Miss Cooper. I just wanted to change up my verbs here. Cool? Bruises, by the way, are just when blood is inside the interstitial space in your body. Remember, interstitial space? What's interstitial space, by the way? Interstitial space is the space between the cells in your tissue. And when blood gets there and kind of dries up and starts to die off there, it gives you that beautiful bluish, yellow, purple thing underneath your skin. That's a bruise. All right, but Miss Bilotic and Miss Cooper, you know what you're doing, right? Burns, by the way, the only thing to know about burns are that they are a local contraindication in general, if they're in a small area. If you have somebody who's burned severely over much of their body, that could be an absolute contraindication. You might not work on that person. You might need a doctor's release to work on that person, but it's unlikely that a burn victim is going to walk in, recently after they've been burned into your place. By the way, if they were burned a year ago, massage away. They might have scar tissue all over them, but there's no reason you can't work on them. And if they're okay with it, you can work directly on their scar tissue. If it's a year old, you're fine. First degree burns tend to be minor. Fourth degree burns are horrendous. You hopefully will never see one in your life. It's actually a burn down into the muscle tissue. Cold sores and fever blisters, you will see them on people. It's one of the herpes viruses. You can work on those people. Please don't turn away people with cold sores and fever blisters, but also it's a local contraindication. Don't touch them. Especially don't touch them and then touch somebody else or touch your eye or your mouth. So, but you can still give them a massage. It's a local contraindication. Miss Felix Osuna will report to us tomorrow about, can you hear me?
Yeah, I can hear.
Good. About I can never say this word. Decubitus ulcers. And you'll tell us how to pronounce that tomorrow because I say it wrong every time I do it.
Okay, sounds good.
Good. Miss Hansen will instruct us about eczema tomorrow, which is something you will come across all the time as a massage therapist. Did you get that, Miss Hansen? Good, thank you. Miss Harper will train us tomorrow on impetigo. Miss Hunter will illuminate us about lice tomorrow. Mr. Kandaris will enlighten us about psoriasis, which is essentially too many skin cells. Did you get that, Mr. Kandaris?
Yeah, psoriasis.
Cool. Miss Monreal will educate us on ringworm. Yay, ringworm. I don't know why I said that. Miss Nguyen will lecture us tomorrow on scabies. Miss Yanez will edify us about scars tomorrow. Miss Petrie will teach us about seborrheic dermatitis, seborrheic dermatitis. Miss Stanley will coach us about shingles, which is a viral infection. And Miss Torres will explain to us about warts. Cool. And nobody's going to talk to us about stretch marks because they're very simply a tearing of the dermis, usually from rapid weight gain. So you see it often in people that were pregnant, right? Rapid weight gain, which you should have when you're pregnant, and so the skin actually gets stretched faster than it can adapt to. It actually tears a little bit, not wide open, and you actually build up more collagen in that area. It actually gets kind of hard and gets kind of like scar tissue in there. You also see it with people that gain rapid weight from just eating a lot really rapidly. Might get stretch marks. You see it sometimes when people go through puberty. We put on weight in different ways when we go through puberty, and so you get stretch marks from that. And you also see it in bodybuilders when they take steroids because their muscles grow faster than their skin can keep up. All those are stretch marks. You can work stretch marks. You can work on them. Probably good for them. Go ahead, Ms. Giannis.
We're telling you like what it is and if we can massage it, right?
Yes. I want to know in layman's terms, and what that means is I want to know in simple English what this thing is. And then I want to know, as a massage therapist, if somebody comes to me with that thing, can I massage that thing? If I can't massage that thing, can I still massage them? Or should I tell them just to get out of there? You know what I mean? Like, I want to know, is it a local contraindication, absolute contraindication, doesn't matter at all? I want to know. So really, you're only telling me two things. What is it? And is it a local or absolute contraindication? Do I just avoid it? Or do I have to avoid the entire person and end the massage? Hopefully, I don't have to end the massage because that's money out of my pocket and a very upset client. It's not just me being money hungry. The clients hate it when you refuse to work on them. And there aren't a lot of situations where that happens because most people know and don't come to you with problems that you can't work on. But anyway, it's good to know. And we're spending a little bit of time on this tomorrow because obviously you're going to be dealing with skin, so it's pretty important we kind of know about these main kind of skin things. Cool. So tomorrow, from everybody, just a couple of minutes on what it is. Teach us. What is it? And what do we do with it? Like, can I massage it? Can I massage the client? Can I massage around it? That kind of stuff. Does that make sense? Okay. You all have your assignments? Yes. Good. Any questions?